Hi, this is Dr. Akhtar and today's topic is anatomy of cornea. Cornea is a transparent tissue. It covers the front of the eye. It forms the interior 1/6 of the outer fibrous coat of the eyeball, 1/6 of the outer coat, while the remaining 5/6 by formed by the sclera. The word cornea has come from kerato. Term kerato in Greek means horn or shield-like. Ancient Greek used to believe that cornea is derived from the same material like that of thinly sliced horn of animal. Embryology, the corneal epithelium derived from surface ectoderm, while the stroma, decimates membrane, endothelium derived from paraaxial mesoderm. The anterior surface of the cornea is elliptical. Posterior surface is spherical. Average diameter is 11.5 mm. Horizontal diameter of the anterior surface HCD is 11.7 and vertical diameter is 11 mm. The horizontal one is very important. The radius of curvature of the cornea is 7.8 mm. Horizontal is important because when HCD is less than 10, it is known as microcornea, while macrocornea when its HCD is more than 13 mm. The radius of curvature is 7.8 mm. When there is difference in the vertical and horizontal radius of curvature, it causes astigmatism. Now the thickness. The central corneal thickness is 0.52 mm. In periphery it is 0.67 mm thick. Central corneal thickness has direct influence in IOP measurement. Central pyometer of the cornea forms the most powerful refracting surface of the eye. The refractive power of the cornea is 45 diopter. This 45 or 43 diopter. It is 3/4 of the total refractive power of the eye. The refractive index of the eye is 1.376. Now the microscopic anatomy. Cornea is composed of 5 layers. They are epithelium, the Bowman membrane, the stroma, then the decimate membrane, and then the endothelium. First of all, the corneal epithelium. It represents 10% of the corneal thickness. Corneal epithelium is stratified squamous and non-keratinized. The cells in the epithelium are held together with the help of desmosomes, with the basal lamina with the help of hemidesmosomes and other filaments. The desmosomes link two cells together. The hemidesmosome attach one cell to the extracellular matrix. The surface corneal epithelial cells has numerous microvilli and microplica, and these cells secrete glycocalyx, which help in adhesion and stability of the tear film. Here you can see tear film, the glycocalyx, and the microvilli. Epithelium is divided into a superficial squamous cell layer here, then the middle wing cell layer, and then the inner basal cells layer. Among these three, the basal cells are only capable of mitosis. New cells formed are pushed anteriorly and change their shape, thereby transforming into wing cells. The cells continue to move anteriorly. Finally, they become superficial cells, after which they disintegrate, lose their attachments. The desmosomes are broken or dissolved and are shed into the tear film. Epithelial stem cells are the undifferentiated pluripotent cells which serve as important source of the new corneal epithelium. They are found in limbal basal epithelium of palisades of Vogt. So in the limbus there are palisades of Vogt. The basal cells are attached to the basement membrane. Here you can see the basement membrane or basal lamina with the help of hemidesmosomes. The basal lamina is an extracellular secretory product of the basal epithelial cells. The main function of this basal lamina is to attach the corneal epithelium with the stroma. Once destroyed, it takes about 6 weeks for basal lamina to regenerate, and it takes normally 7 days for replacement of entire corneal epithelium. The next layer is Bowman layer. Here you can see Bowman's membrane. It is named after English anatomist ophthalmologist William Bowman. It is an acellular tough membrane-like zone situated between corneal epithelium and stroma. It is 8 to 12 micrometer thick and composed of randomly arranged collagen fibers. Though the collagen fibers are finer than those found in corneal stroma and randomly arranged, these collagen fibers are continuous with that of anterior stroma. That's why many authors consider it a modified region of anterior stroma. Because of the compact arrangement of collagen fiber, it is comparatively resistant to trauma. However, once destroyed, it cannot be regenerated. Bowman's membrane is not a basement membrane like a decimet membrane. Next is the corneal stroma. The stroma are also known as substantia propria. It occupies 90% of the total corneal thickness. It is composed of collagen fibrils, keratocytes, extracellular ground substances. Collagen components constitute more than 70% of the dry weight of the cornea. Collagen fibrils with uniform 25 to 35 nanometer diameter are arranged in flat bundles called lamellae. The lamellae extend from limbus to limbus, oriented at various angles to one another. Collagen fibers form approximately 300 lamellae in corneal stroma. Two important corneal collagen fibers which account for the transparency of cornea are: collagen fibers are highly uniform in diameter, from 25 to 35 nanometer. The distance between two corneal fibers is also highly uniform. It is 41.5 nanometer. Corneal transparency is mainly dependent on the arrangement of these collagen fibers in stroma. Mean diameter of individual collagen fiber and mean distance between collagen fiber are almost same, and both of them are less than half of the wavelength of visible light, which is 400 to 700 nanometer. As a result, scattering of an incident ray of light by a collagen fiber is cancelled by interference from other scattered rays of light. It is known as destructive interference. The corneal clouding and corneal edema occurs due to accumulation of fluid, which increase the distance between the collagen fibers. The extracellular matrix or ground substance found in the cornea are mainly glycosamine glycans. The primary glycosamine glycans of the stroma are keratin sulfate. It forms 65% of the total glycosamine glycan content, and chondroitin sulfate. Among the cellular components, keratocytes, which are corneal fibroblasts, they are the major cell types of the stroma. They occupy 3 to 5% of the stromal volume. They are spindle shaped and cross section found scattered in between lamellae of the collagen fibers. They synthesize collagen and extracellular matrix component and thus maintain the stroma. The next layer is dual layers. It is very strong and impervious to air. The next layer is decimet membranes. It is a thick basement membrane. Here you can see decimet membranes are secreted by endothelium. It is produced constantly. It thickens throughout life. 3 micrometer at birth, increases to 10 micrometer in adults. Decimet membranes does not adhere strongly to the stroma. It can be surgically dissected as a sheet. Though no elastic fibers are present, decimet membrane exhibit elastic property due to the particular arrangement of collagen fibers. The membrane terminates near limbus as Schwalbe line. In case of decimet membrane detachment or tear, the membrane curls toward the stroma inwards because of the elastic property of decimet membranes. The lens capsule, which is also a basement membrane, has similar tendency but curled outwards towards anterior chamber. Unlike the attachment of Bowman membrane in corneal stroma, the decimate membrane is comparatively weakly attached to corneal stroma, and this surface is sharply defined. Decimate membrane is a tough layer which has resistance to enzymatic degradation by phagocytes and toxins. In corneal ulcer, a decimate membrane remains intact and often herniates out as a result of increased intraocular pressure. It is known as dysmetocele. The last layer is corneal endothelium. The name endothelium is a misnomer. Basically, corneal endothelium is a simple squamous epithelium. The shape of the individual cell is hexagonal, which forms continuous mosaic pattern, best seen in specular microscopy. The endothelial cells are interconnected with each other with various junctional complexes like zonula occludens, macula adherens. These cells possess ion transport system which is known as endothelial pump. These endothelial pumps circulate the water content of corneal stroma. Endothelial cells cannot divide or replicate. With aging, the cell density of the endothelium decreases. It is compensated by increase in cell size known as polymegatism or shape pleomorphism. As these endothelial cells are involved in corneal hydration, which helps in maintenance of corneal transparency, endothelial cell density below 800 cells per mm square lead to corneal decompensation. So the young adult cell density is about 3000 cells per mm square and it decreases 0.6% per year. Now what is the corneal response to injury? When an injury occurs in corneal epithelium, the basal cells are moved to the damaged area and subsequent cellular proliferation from basal cells fill the defect. Bowman membrane does not regenerate. The wound in Bowman's membrane is replaced by stroma like fibrous tissue or epithelium. In response to trauma to corneal stroma, there is increase in number of keratinocytes and the ground substances and the collagen fibrils secreted by the keratinocytes. However, the stromal tissue thus produces different diameter of the newly formed stromal collagen is larger compared to those found in sclera than the normal stromal collagen. Although the newly formed collagen fibrils are not well organized and lack of normal tensile strength of the collagen fibril, the response to various layers of cornea to trauma or injury is this was the response. Now the blood in normal condition, cornea does not contain any blood vessels, but the anterior ciliary artery, which is a branch of ophthalmic artery, it forms a vascular arcade in the limbal region and helps in corneal metabolism and wound repair by providing nourishment. Absence of blood vessel in the cornea is one of the contributing factors for its transparency. Conditions when oxygen supply to the cornea decrease are in infections when the regulatory mechanism tries to increase blood supply to the affected part. Growth of abnormal vessels occur in cornea, which is called vascularization of cornea. With the restoration of normal environment within the cornea, these vessels stop carrying blood, but their outlines are visible, which is known as ghost vessels. The nerve supply of cornea. Cornea is one of the highly sensitive tissue of the human body. Density of the nerve ending in cornea is about 300 times that of the skin. An area of 0.01 mm square, cornea may contain as many as 100 nerve endings. Cornea is primarily innervated through the ophthalmic branch of the trigeminal nerve. The ophthalmic division of trigeminal nerve has three parts: frontal nerve, lacrimal nerve, nasociliary nerve. The nasociliary nerve provides sensory innervation to the cornea. Pathological conditions which lead to loss of corneal epithelium cause severe pain due to exposure of corneal nerve endings. Now what occurs at limbus? At limbus, this corneal epithelium becomes bulbar conjunctival epithelium. The Bowman membrane, it becomes continuous with the lamina propria of the conjunctiva and tenon capsule. The stroma becomes sclera. The decimate membranes become the Schwalbe line. The endothelium lines the trabecular meshwork and becomes continuous with the anterior surface of the epithelium. Now the signs of corneal disease. First of all, the superficial. The number one is punctate epithelial erosions. They are tiny epithelial defects. They stain with fluorescein, here you can see, and rose bangle. Here you can see rose bangle. They are generally an early sign of epithelial compromise. The causes include a variety of stimuli. The location of the lesions is important. Superior lesions are caused by vernal disease, chlamydial conjunctivitis, it is a bacteria, superior limbic keratoconjunctivitis, floppy eyelid syndrome, mechanically induced keratoconjunctivitis. The interpalpebral lesions, they occur in dry eye but can also be inferior. Also occur in reduced corneal sensation and ultraviolet keratopathy. Inferior lesion occurs in chronic blepharitis, leg ophthalmos, eye drop toxicity. The eye drop toxicity, self-induced toxicity, aberrant eyelash and entropion. The diffuse lesions occur in some cases of viral and bacterial conjunctivitis, toxicity drops. Central lesion occurs in prolonged contact lens wearing. The next is sign is punctate epithelial keratitis. The number one was punctate epithelial erosion, and this is punctate epithelial keratitis. It appears as granular, opalescent, swollen epithelial cells, focal intraepithelial infiltrates, visible unstained but stained well with rose bangle and variably with fluorescein. What are the causes? The causes are infections such as adenoviral, chlamydial, molluscum, herpes, microsporidial, and systemic viral like measles and varicella rubella. Other causes known as Thygison and eye drop toxicity. Thygison superficial punctate keratitis. This one is secondary to molluscum infection. The next sign is subepithelial infiltrates. The subepithelial infiltrates, they are tiny and they are subsurface. These are the foci of non-staining inflammatory infiltrates. What are the causes? Causes are severe, prolonged adenoviral conjunctivitis, adenoviral, herpes keratitis, adult inclusion conjunctivitis, the marginal keratitis, rosacea, and Thygison superficial punctate keratitis. Next sign is superficial punctate keratitis. It is a non-specific term. It describes any corneal epithelial disturbance of dart-like morphology. Next is filaments. Filaments, here you can see they are strands of mucus and they are admixed with epithelium. They are attached at one end to the corneal surface. That stain well with rose bangle. One end is unattached. It moves with each blink. Gray subepithelial opacities may be seen at the side of attachment. The dry eye is by far the most common cause. The most common cause is dry eyes. Other causes: superior limbic keratoconjunctivitis, neurotropic keratopathy, long-term ocular patching, essential blepharospasm. Epithelial edema. Subtle edema may manifest with loss of normal corneal luster. More commonly, abundant tiny epithelial vesicles are seen. Here you can see the tiny vesicles. Bullae form in moderate to severe causes. Here you can see the bullae. The cause is usually endothelial decompensation. that it can also occur after acute elevation of intraocular pressure. The next superficial sign is neovascularization, caused by chronic ocular surface irritation or hypoxia, such as in contact lens wear. Pain is superficial neovascularization, but it is accompanied by degenerative subepithelial change. These were superficial signs. Now the deep signs. Infiltrates. Infiltrates are yellow, gray, white opacities located initially in the anterior stroma. They are associated with limbal conjunctival hyperemia. These are stromal foci of acute inflammation. They are inflammatory cells, cellular extracellular debris, including necrosis. The key distinction between sterile and infective lesions. So the mnemonic is PEDAL. There are 5 points: pain, epithelial keratitis, epithelial defects, discharge, anterior chamber reaction, and location. When there is seporative keratitis, it is caused by active infection with bacteria, fungi, protozoa, and virus. The non-infectious keratitis is sterile due to immune hypersensitivity response to antigen in marginal keratitis with contact lens wears. So in infective, the infiltrates are larger, in sterile they are smaller. In infective, they are rapidly progress. In infective lesions, they have very common large epithelial defect. There is moderate to severe pain, purulent discharge. They are single typically, while the sterile are multiple, and it is unilateral. The infective is there is severe anterior chamber reaction, and the location is often central, and the adjacent corneal reaction is extensive. Next is ulcer. There is tissue excavation in the ulcer, and there is epithelial defect, usually infiltration, necrosis. Next is melting. In melting, there is tissue disintegration in response to enzymatic activity with mild no infiltrate, peripheral ulcerative keratitis. Vascularization due to a variety of stimuli. The venous channels are seen. The arterial feeding vessels are smaller, require high magnification. The non-perfused deep vessels appear as ghost vessels, best is detected by retroillumination. The lipid deposition here you can see may follow chronic inflammation with leakage from corneal nerve vessels. Folds and descending membrane striate keratopathy result from corneal edema. Causes inflammation, trauma including surgery, and ocular hypotony. The next is dysmetocele. It is a bubble-like herniation of descending membrane into the cornea. So dysmetocele is a bubble-like herniation of descending membrane into the cornea, plaguing a defect that would otherwise be full thickness. Breaks and descending membrane due to corneal enlargement. For example, half stria in infantile glaucoma, or deformation such as keratoconus, bird trauma, acute influx of aqueous into the corneal stroma known as acute eye drop. It can follow. The Seidel test, it demonstrates aqueous leakage. A drop of 1%, 2% or 2% fluorescein is applied to the surface of the eye. Using a slit lamp, the cobalt blue filter is used to detect a change in color from dark orange to bright yellow green, secondary to localized dilution at a site of leakage. These are documentation of clinical signs. clinical signs should be illustrated with a color-coded label diagram. Measuring lesions dimension is particularly useful to facilitate monitoring. Slit lamp photography is an increasingly used supplement or alternative. The opacities such as scars and degeneration are drawn in black. Epithelial edema is represented by fine blue circles. Epithelial edema by fine blue circles. Stromal edema is blue shading. Stromal edema. And folds and decimate membrane is wavy blue lines. Folds and decimate membranes. Hypopyon is in yellow. Blood vessels are added in red. These are the blood vessels. Superficial vessels are wavy lines that begin outside the limbus. Deep vessels are straight lines that begin at the limbus. Superficial vessels and deep vessels. Pigmented lesions such as iron lines and Krukenberg spindles are shown in brown. So these are the pigments. Now specular microscopy, it is the study of corneal layers under very high magnification, 100 times greater than slit lamp biomicroscopy. It is mainly used to assess the endothelium, which can be analyzed for cellular size, shape, density, distribution. The healthy endothelial cell is a regular hexagon, and a normal cell density in a young adult is about 3000 cells per millimeter square. Now what occurs in specular microscopy? A light beam of the specular microscope passes through the cornea. It encounters a series of interfaces between optically distinct regions. Some light is reflected specularly like a mirror back toward the photomicroscope, forms the image that can be photographed. The indications for the evaluation of functional reserve of the corneal endothelium prior to intraocular surgery is the most common indication. Clear cornea with normal thickness on pachymetry is not necessarily associated with normal endothelial morphology or cell density. Corneal edema is considerably more likely to occur with a cell density below 700 cells per mm square, but unlikely above 100,000 cells per millimeter square. Next indication is donor cornea evaluation, and another indication is demonstrate pathology, particularly corneal guttata, decimate membrane irregularities, for the posterior polymorphous dystrophy. Corneal topography, it is used to image the cornea by projecting a series of concentric rings. Here you can see. These concentric rings of light, they are projected on the anterior surface and they constitute a placebo image. The reflected light is analyzed using a computer software to produce a detailed surface map. A major application is the detection and management of corneal ectasia, principally keratoconus. Screening for corneal ectasia is especially important prior to refractive surgery. It is used occasionally for contact lens fitting to measure corneal thickness. Skin plug imaging is new technology that may offer advantage in topography imaging. Anterior segment OCT and ultrasound biomicroscopy can also be used to image the cornea. In astigmatism, these rings become crowded. The spacing into color-coded images, here you can see the color-coded. The hot colors are for steep cornea and cool color for flat cornea. Principles of treatment. First of all, how to control infection and inflammation. How to control infection and inflammation is by antimicrobial agents. It should be started as soon as preliminary investigations have been performed. The choice of antimicrobial agent is determined by the likely etiology. According to clinical findings, the broad spectrum treatment is generally used initially, with more selective agents introduced if necessary when the results of investigation are available. Topical steroids should be used with caution, as they may promote replication of some microorganisms, notably herpes simplex virus and fungi, and retard reparative process such as reepithelialization. Topical steroid, nevertheless, they are vital in a range of conditions for the suppression of destructive vision compromising inflammation. Other treatment is systemic immunosuppressive agents. They are useful in some conditions, particularly autoimmune disease. Promotion of epithelial healing. The reepithelialization is of great importance in corneal disease because thinning seldom progresses if the epithelium is intact. Reduction of exposure to toxic medication and preservatives wherever possible. Lubrication is important for promotion of epithelial healing with artificial tears, unpreserved, and ointment. Taping the lid closed as a temporary measure is often used as nocturnal adjunct. Antibiotic ointment prophylaxis should be considered. Bandage soft contact lenses should be carefully supervised by exclude superinfection and duration kept to a minimum. The bandage contact lens indications are promotion of healing by mechanically regenerating corneal epithelium from the constant rubbing of the eyelids. The BCL, bandage contact lens, improve comfort in the absence of a larger corneal abrasion, and also the BCL seal a small perforation. The surgical eyelid closure is particularly useful in exposure and neurotropic keratopathy, as well as in persistent epithelial defect. The lid closure may be used as a conservative method to heal an infective ulcer in selected cases, such as an eye with no visual potential in a patient with severe dementia. Botulinum toxin injection into the levator muscle to induce a temporary ptosis for 2 to 3 months. Temporary or permanent lateral tarsorrhaphy, medial canthoplasty, occasionally central tarsorrhaphy. Here you can see central tarsorrhaphy. The Gunderson flap, conjunctival Gunderson flap will protect, allow healing of a corneal epithelial defect, particularly suitable for chronic unilateral disease in which the prognosis for restoration of useful vision is poor. Buccal mucosa is an alternative. Amniotic membrane graft over a persistent epithelial defect is shown for persistent unresponsive epithelial defects. The tissue adhesives. Cyanoacrylate glue seal small perforation can be applied to one side of a bespoke trim patch of sterile plastic drape pressed over the defect after the edges are dried with a cellulose sponge. Patch remained in place to seal the defect. BCL is inserted for comfort. The limbal stem cell transplantation used if there is stem cell deficiency in chemical burns, cicatrizing conjunctivitis. Source of the donor tissue may be the fellow eye, autograft in unilateral disease, or a living or cadaver donor, allograft, when both eyes are affected. A newer technique involves in vitro replication of the patient's own stem cell with subsequent reimplantation of the enhanced cell population. Smoking retards epithelialization and should be discontinued. Thanks a lot.